Hi, everyone. I'm Nsini Umoh, Traumatic Brain Injury Program Director for the National Institute of Neurological Disorders and Stroke, and I'll be providing you with a brief overview of the NINDS TBI Classification and Nomenclature Initiative, which is a step towards a comprehensive characterization of TBI. So before I jump into the details, I want to remind everyone how we actually got to this point. So if you're like me, you've heard for many years that the current TBI classification system needs to be improved. In fact, there was a report that came out a couple of years ago, which was highlighted by military.com, that described the current classification system as actually being outdated and imprecise. In fact, experts wrote that these terms can actually obscure the severity of head injuries, leading to inadequate treatment and potential harm to the patient. In addition to that, I think it's important to note that there are no modern treatable diseases with such a crude and imprecise classification system. In addition, mild TBI is not always mild, such that severe TBI is not always severe. It's unclear, what exactly is moderate TBI? How about complex mild TBI, severe TBI, and even moderate TBI? What do those terms actually mean when it comes down to it? As well as, we need to keep in mind that the clinical severity lies along a continuum. There's limited association with mechanism with this current classification system, and there's no effective targeted treatments for mild, moderate, and severe TBI. These terms lead to treatment bias, and most importantly, we have to keep in mind that patients and families do not want us to continue using these terms. So now, let's get to the real life why. And by that, I mean, what exactly are patients saying and those with lived experience actually saying about these terms? Well, at our most recent workshop in January, we actually had a panel for those with lived experiences. And some of the things that they actually said was that most doctors and nurses who diagnosed my mild TBI as severe could not imagine I'd be alive, let alone walking and talking on the stage today. Another panelist: having been diagnosed with a mild concussion has created substantial challenges in my recovery. I've constantly had to fight to be taken seriously. Another panelist said that severe TBI is a term that reinforces resignation, and also mild TBI is a term that promotes denial about the symptoms that many patients may endure for long periods of time. So overall, these terms have the tendency to invoke inherent bias, and I think we must do better with this. And the only way to do this is by continuing to get input from people with lived experience. So in line with this thought process and the research community's overall need to update the current classification system, the National Academies published a very timely report titled Traumatic Brain Injury, a Roadmap for Accelerating Success. And one of the key takeaways from this report is that TBI care often fails to meet the needs of the individuals, families, and communities affected by this condition, as well as public and professional misunderstandings are widespread with respect to the frequency manifestations, long-term consequences, and proper detection, treatment, and rehabilitation of TBI. So within this report, there were 8 recommendations that were highlighted. And as you can see, the first recommendation was to create and implement an updated classification system for TBI. So within that report, there seemed to be confirmation, at least to some extent, that there is some general consensus in the field about what needs to be done. But now the question is how? How is this going to be done? Who would be involved in creating this updated classification system? And to take it even a step further, who would be involved in the overall guidance and strategic vision for this initiative? So NIH has assisted with facilitating the logistical work associated with this effort, but it's really the subject matter experts and the work of the steering committee that have provided overall guidance for this initiative. It's been a tremendous pleasure to work with these individuals over the past year to plan this workshop. They're all very well-known individuals within the field, but I do want to quickly mention them. So if you want to bear with me, starting with the top left, we have Dr. Jeff Manley, Chief of Neurosurgery at Zuckerberg San Francisco General Hospital and Professor and Vice Chairman of Neurological Surgery at UCSF. He is also a trauma neurosurgeon and co-director of the Brain and Spinal Injury Center. Sliding over to the right is Dr. Kristen Dams O'Connor, clinical neuropsychologist, professor in the Department of Rehabilitation Medicine and Neurology and director of the Brain Injury Research Center at Mount Sinai. Also, Dr. Mike McCrae, professor of neurosurgery and neurology and director of brain injury research at the Medical College of Wisconsin. And we also have Dr. Andrew Moss, neurosurgeon and professor of neurosurgery at Antwerp in Belgium. And also our NINDS staff, including Dr. Hiba Awad, TBI program director at NINDS. She oversees the preclinical TBI research, and we work hand in hand. We also had Dr. Adele Doporowski, health program specialist at NINDS, and she's really been instrumental in supporting this effort, and we certainly could not have done this without her. So that brings us to the workshop that was held in January this year, which highlighted the importance of clinicians using results from neuroimaging and blood-based biomarkers, as well as considering psychosocial and environmental modifiers to classify patients as well, while also keeping in mind that a person's TBI classification may change as a person's condition evolves over time, which highlights the importance of retrospective classification as well. So the primary aims of this initiative was to produce a more precise TBI classification and nomenclature system, which will be validated and disseminated. We also want to identify current gaps in research topics that may inform refinement and updating of the new TBI classification nomenclature system. Ultimately, to work towards developing and implementing a global solution for multidimensional TBI characterization and classification, which is all going to move us beyond the terms that we commonly hear, such as mild, moderate, and severe TBI. So there were several working groups associated with this initiative, including working group 1, which is clinical symptoms. It looks at days 1 and 14, as well as the second working group, which is imaging, also looking at days 1 and 14. We had a third working group specifically for blood-based biomarkers. We had a working group for psychosocial and environmental modifiers, as well as a knowledge to practice working group. And that working group was really instrumental in helping us to figure out how do we go from this great idea that all these subject matter experts have come up with and actually get it into practice. So that working group was their objectives were focused specifically on that. And we also had a working group for retrospective classification as well. And then each of the working groups were charged with specific objectives related to this overall initiative. So now, one of the main questions is what actually came out of this meeting. What is the new proposed way of doing things? So experts came up with this model called the CBIM model, the C standing for clinical, B standing for blood-based biomarkers, and I standing for imaging. And these are really the pillars that are critical to characterization and classification on acute injury. And within that, we also have modifiers, which are factors that can influence assessment, management, recovery, and outcome. And this is really getting at the social determinants of health aspect of TBI classification. So with each component, we have core information and expanded details. For the clinical component, we have core factors such as the GCS score. For biomarkers, we look at GFAP, UCHL1, S100 beta. For imaging, a core is the CT when available, positive or negative, common acute TBI pathologies, and mass effect when present. And also we have modifiers, which includes injury factors, patient factors, as well as community and society factors as well. And again, for each component, there is an expanded version which considers additional factors to take into consideration. So now we have a proposed framework for an improved characterization and classification system. But now the question is, where do we go from here? What are the next steps to actually translate this knowledge into practice? Well, I think this new proposed system must be pragmatic for clinical use and adaptable for research applications. We have to anticipate and overcome potential hurdles to implementation and penetration. I think it's important to keep a note the aspect of policy and pathway to reimbursement, as well as get buy-in from a wide variety of stakeholders, including specialists and professionals in other settings. We want to make sure that we note how important it is to monitor penetration and impact of this new system on clinical care and research. Because ultimately, how will we determine the effect that this new classification system is actually having in the real world? So what are some of the key do outs and the action from the January meeting, and what is the action plan that's in process now? So we're currently in the process of refining and operationalizing the CBIM pillars. We want to finalize the CBIM framework, which includes the core and expanded characteristics. We want to pilot test this in existing data sets to provide evidence in support of the pillars. We also want to prepare a consensus document. We want to have extensive intra and inter-pillar analysis to provide further support. And also, we want to develop and execute an implementation plan in partnership with our stakeholders. And finally, we want to validate this new model, this CBIM model, in order to see how this is actually working in prospective studies as well. So before I close, I would like to acknowledge all of the individuals that participated in the workshop and the work leading up to the workshop, including our working group chairs, our steering committee members, which I mentioned in the beginning of this presentation. We had so many working group members, part of these 6 working groups. We definitely couldn't do all this work without them. So we have many working group members associated there. I want to thank the individuals that were brave enough, our individuals with lived experience. They were brave enough to tell their stories back in January, and I'm so thankful for that. We also had plenty of organizational support, and I also want to thank the support through NINDS and NINDS leadership as well. And this is certainly not an effort that we want to keep just within the states. So we had several members from different countries to provide that international perspective on this proposed classification system. So with that, I just want to leave you with this new proposed model that the experts came up with based on the evidence that we have available, which is a CBIM model. Again, clinical, blood-based biomarkers, imaging, and the modifiers component. And I think with all of this taken into consideration, this is going to help us move beyond the limitations that we currently face with the mild, moderate, and severe terms. Thank you.